let's begin. So the conduction pathway in the heart start from SA node. So what is the location of SA node? SA node located at
right atrium.
it's near the opening of superior vena cava.
No.
Right?
Yes.
So mainly at right atrium. Right? So what is a blood supply of this SA node? Blood supply of SA node. Very high yield.
Yeah, that'll be the coronary artery.
Which coronary artery?
I'm the
Right coronary
coronary.
right coronary artery. This is again a high yield stuff. Okay. So SA node is located at the opening of superior vena cava at the right atrium. Right? So
yes.
SA node is also known as a pacemaker of heart. Right? So normally impulses start from the SA node. And the yesterday session we discussed how the action potential generate in SA node and AV node, right?
Yes.
Okay. From SA node, the pulses are traveling from right atrium to the left atrium through Bachmann bundle. So Bachmann bundle involve in traveling of the nerve impulses from right atrium to left atrium. And this is another pathways that transmit the impulses from SA node to AV node. So this is AV node. Can anybody tell me the location of AV node? AV node location. AV node location. Interatrial septum. Right?
Yes.
So what is the blood supply of AV node?
Right coronary itself.
Right coronary. Right?
Coronary.
Right coronary artery. Okay. So AV node, basically there is a AV nodal delay. What is the significance of AV nodal delay? AV nodal delay. What is the significance of AV nodal delay? Hello?
Coronary filling.
Okay, it's give time for ventricular filling, right?
Ventricular filling. Yes, yes.
Okay. So SA node, AV node, blood supply location, high yield stuff. Where it is located, what is the blood supply of these nodes, right? So from the AV node, the impulses are travel to the bundle of his, right? Bundle of his. And this bundle of his divided into the two branches, right bundle branch, left bundle branch. So left bundle branch further divided into the left inferior fascicle and left posterior fascicle. And this further divided into the Purkinje fiber. And this is again, this is a Purkinje, this is Purkinje fiber, right? So this is some general pathway how the impulses travel in the heart. Okay. So which of the following part of the heart has slowest speed of the conduction? Slowest speed of conduction of impulses.
AV node.
AV node, right?
Yes.
AV node. That why this slowest conduction lead to AV nodal delay, which is important for
Ventricular filling. Ventricular
ventricular
filling.
filling, right?
Yes.
AV node. And which of the following part of the heart has highest speed of conduction?
Purkinje fibers.
It's a Purkinje and
Pur-
bundle of his. Purkinje and
Bundle of
All of this.
okay. So this is some basic stuff from the ECG, right? The basic stuff from the ECG. So this is a P wave. So ECG is basically electrical activity of heart, and it is followed by mechanical activity. So the contraction of heart is a mechanical activity. First electrical activity takes place, then mechanical activity takes place, followed by mechanical activity, right?
Right.
Okay. So first, SA node fires. So this is basically P wave represent atrial depolarization.
contraction.
No.
Depolarization.
It's a depolarization. It doesn't represent the atrial contraction. After the P wave, then the contraction takes place, right? So it is a electrical activity, right?
Okay. Understood.
So this complex QRS, this QRS intervallar complex represents ventricular depolarization, right?
Depolarization. Yes.
So next
Yes.
is T wave. T wave represent
Repolarization.
ventricular
Repolarization.
repolarization, right? What is the significance of this U wave?
It indicates hypokalemia.
And sometime hypokalemia and sometime
Bradycardia.
bradycardia, decrease heart rate. Okay. So can anybody tell me the difference between the interval and segment? Interval was segment on ECG.
Okay. So if we look at, for example, the PR, when you look at the PR interval, basically we are looking at the time it takes for the atrial.
Doc, listen. You are right. I'm asking about the journal. Interval contain a wave, right? And segment is basically straight line on ECG, isoelectric. Straight line are isoelectric, So let's suppose this is PR interval. So it contains this P wave, right? It starts from P and ends at the Q. It doesn't include R wave. PR interval doesn't include R. It starts from the P and ends at Q, right? So let's suppose ST segment. So this is ST segment. So it starts from this point and ends at this point. So this is straight line, isoelectric line. So ST segment is isoelectric or straight line. Does it make some sense? Does
Yes.
it make some sense?
Yes. Yes.
Okay. So what is the significance of PR interval? Clinical correlation, very high yield stuff. PR interval represents AV nodal delay, right? So if the delay is increased, if this delay is increased, what happens? PR interval increase or decrease?
The block. Orbits. Block. Hello?
Okay, if the conduction or the AV nodal is prolonged, it means there is increased PR interval. It is opposite, right? It simply means the conduction velocity. If the conduction is slow, it means the PR interval is prolonged, longer time take, right? Longer time needed. If it is faster, it means PR interval is decreased. Okay.
Decreased.
Can anybody tell me any drug, one drug that increase the PR interval? Beta blocker.
Beta blocker.
Any pathology that increase the PR interval?
Block. Orbits type 1 block.
Yes, heart block. Heart block. So we will discuss these heart block in detail. Don't worry about this when we discuss detail in ECG. Okay. Now some basic stuff. Right? So, so can anybody tell me any condition that lead to the absent P wave? Very common condition.
Atrial fibrillation. Atrial fibrillation.
AFib.
Absent P wave.
AFib.
Absent P wave, atrial fibrillation. What about the rhythm in atrial fibrillation?
Irregularly irregular. Irregularly irregular.
Yes, irregular rhythm.
Yes.
Okay. What is the significance of ST segment? Clinical significance.
Elevated in MI. Like there are two
RMI.
types. In one it is elevated and the other it is depressed.
Okay. If it is elevated like this from this, so it is ST segment elevation, myocardial infarction, STEMI. And when it is depressed, it means non-ST segment elevation, myocardial infarction. Right?
Yes.
Okay, so ST segment elevation indicate which kind of infarct? Transmural infarct. What is the meaning of transmural infarct?
The whole segment of the myocardium is affected.
And
Whole thickness
yes,
of the myocardium
yes,
is
you are
affected.
right. What about non-ST segment elevation, myocardial infarction?
Only the interior is affected. Endocardium is affected.
Yes, subendocardial infarct. Subendocardial infarct. What about the cardiac marker in ST segment elevation and non-ST segment elevation myocardial infarct? Raised in both conditions, raised in only ST segment elevation myocardial infarction, or decrease in both conditions? What do you think?
Sorry, sir. Sorry, can you please repeat the question?
I'm talking, what about the level of the cardiac marker in ST segment elevation myocardial infarction and non-ST segment elevation myocardial infarction?
In both it is elevated.
Yes, in both it is elevated. What does it mean? Increased troponin mean damage of which thing? Damage of which thing? Increased troponin. This is some high yield stuff. Increased troponin mean damage of which structure of cell?
Membrane.
Yes, plasma membrane. Which kind
Plasma
of
membrane.
injuries? Which kind of cellular injuries?
Necros.
Reversible or sorry?
Reversible injury.
Irreversible injury. So this is some correlation with general pathology. So I already mentioned when the things are overlap, it means it is a high yield, right? The troponin, plasma membrane damage. Plasma membrane damage means irreversible cell injury, right?
Yes.
Okay. So does T wave has any, what does T wave clinically indicate? If T wave invert, this T wave inversion take place. T wave inversion.
Hyperkinesia.
It indicates recent MI or ischemia, right?
Okay.
Okay. Can anybody tell me what is the clinical QT interval? QT interval include which of the following things? QT interval include ventricular depolarization, ventricular repolarization, and mechanical contraction, and plus this mechanical contraction of ventricle, right?
Yes.
Yes.
Because after the QRS complex, mechanical contraction of the ventricle take place, and then the repolarization, right?
Yes.
So can anybody tell me the clinical importance? Clinical importance. What?
It is elevated in class 1, 1A and 3.
Okay. So you say that increased QT interval in class 1A and
3.
3. 1A is which class?
1A belongs to Uh,
Sodium channel blocker. And
sodium
3,
channel. Yes. 3 is potassium channel blocker.
okay. So there are a lot of drugs that increase the QT interval, and you have to cram these drugs like some opioids, some antidepressants, some antibiotics. Okay, so you have to cram these drugs very high yield. Like, can
Okay.
anybody tell me the which class of the antibiotic increase the QT interval?
Is it fluoroquinolone?
Fluoroquinolone, absolutely right. Macrolide. And fluoro
Hello.
opioids, right? Does
Yes.
anti-HIV drug increase QT interval? So protease inhibitor that used in HIV treatment also increase QT interval. Protease inhibitor, right?
Yes.
Okay. There are a lot of drugs that are high yield that increase the QT interval. I'm not going to detail in these drugs. Okay. So can anybody tell me any congenital anomalies that increase QT interval? Congenital anomaly.
Fanconi syndrome, renal syndromes.
Okay. What about, I will give you a hint. Some channelopathies.
Romano
Hereditary
syndrome.
Romano-Ward syndrome. Absolutely right. One more. Channelopathies. Romano-Ward syndrome is which kind of it? Autosomal recessive or dominant? Autosomal dominant or recessive?
Dominant.
Dominant. Right? I think one more is some unique name. I think it's the Jarvell-Lange syndrome. Right? So it has sensory neural deafness also takes place in this syndrome. So these are important stuff. So in both of these syndromes, Romano and Jarvell, I think it's the Jarvell. Which ion channel is mutated? Which ion channel are mutated?
Potassium.
Potassium, absolutely right. So the potassium channel are mutated, right?
Yes.
Okay. So can anybody identify this condition? This ECG.
WPW.
Okay, so this is Wolff-Parkinson White syndrome. Wolff-Parkinson White syndrome.
Abnormal communication between atria
Abnormal
and
communication between.
atria and ventricle.
Okay. So there is abnormal communication between atria and ventricle. Let's suppose this is a right atrium. This is left atrium. This is right ventricle. This is left ventricle. So normally what happens? SA node firing and then AV node. This is normal. So what happened in Wolff-Parkinson-White syndrome, there is an accessory conduction pathway that bypass this nodal AV node, right? And this accessory pathway is known as bundle of Kent, right? They directly connect atria to ventricle by bypassing AV node, and these known as bundle of Kent. Okay, so these are some ECG that show the delta wave. So the delta wave is widened KURS, and the PR interval is short, right? So the PR interval is short in Wolff-Parkinson-White syndrome. So it is a most common type of ventricular pre-excitation syndrome. Ventricular pre-excitation syndrome.